Assalamualaikum. Today I will be discussing about amenorrhea. Amenorrhea is actually absence of menses in a woman of reproductive age. There are basically two main types of amenorrhea. It can be primary or secondary amenorrhea. Primary amenorrhea is defined as when there is no menstruation by the age of 14 years and it is accompanied by failure of proper development of secondary sexual character. And this is one definition, and there is another definition as well which says that if there is no menstruation by the age of 16 years with proper development of secondary sexual character. So first one is without sexual characters, the other secondary sexual characters, and second one is that other characters are normal, just the menstruation is delayed. So up to 16 year it is acceptable, but after 16, at the age of 16 year, we will label it as primary amenorrhea. Then secondary amenorrhea. Secondary amenorrhea is the absence of periods for at least 3 months if the patient had previous regular cycle, and now 6 months if the patient has previously oligomenorrhea. So this is also a relevant term. If previously regular cycles, then the absence of periods for 3 months, and if previously oligomenorrhea, then the absence of period for at least 6 months. Okay. Then causes of amenorrhea. Causes of amenorrhea are four major ones. First one is anomalies of the outflow tract, like the anomalies of the female genital tract. Second one is primary ovarian insufficiency. Third one is central anomalies, which is the hormonal pathway for hypothalamic and pituitary axis, which we called as hypothalamic pituitary axis. Then the endocrine disorders are also the cause of amenorrhea. So let's see about the abnormalities of the outflow tract. Imperforate hymen is most common cause of outflow tract anomaly. In this case, female with teen age, she will have amenorrhea, but there will be normal secondary sexual development. There will be intermittent lower abdominal pain. Retention of urine will be there. When you will palpate the abdomen, there will be lower abdominal swelling. There will be bulging bluish membrane at lower end of the vagina when you will do the vaginal examination. The management of this condition is incision of the hymen, and if there is vaginal atresia completely, then we will go for vaginoplasty. Other disorders can be androgen related, which one I described as the endocrine disorders. So androgen insensitivity is one of them. There will be absence of pubic hair in such female, occasional presence of inguinal masses. Karyotype will be XY. Male level range of testosterone, when you will check the testosterone of the female, the ratio will be like the male, and there is 22% chance of malignancy in gonads. Gonads should be removed once breast development and attainment of secondary sexual characters are done in female. Okay, in this case we were saying that there are inguinal masses. These are actually the gonads, and the karyotype is also XY, but it is very important to remove these gonads to prevent chances of malignancy. Then gonadal dysgenesis, it can be XX, XY or X0 karyotype. One with X0 karyotype is very famous. This is Turner syndrome. The patient will have short neck, short stature, webbed neck, also short and webbed neck, and there will be long hairline. Beside this, we are seeing that these are usually females with the with androgen insensitivity. Here, if XY chromosome at the time of diagnosis, these gonads are not secreting hormones. So it's unlike androgen insensitivity. In androgen insensitivity, we have studied that it is important to remove the gonads because they are secreting hormone and they can cause malignancy. Here, if the genotype is XY, then these gonads are not secreting hormones. Then next one is premature ovarian failure. Premature ovarian failure can be autoimmune. If autoimmune, it is associated with other autoimmune diseases like thyroiditis, like diabetes mellitus type 1, myasthenia gravis, and parathyroid disease. And secondly, it can be associated with the iatrogenic causes like the chemotherapy and radiotherapy. And management for premature ovarian failure is estrogen and progesterone. Okay, and premature ovarian failure is usually labeled as early menopause. Before the age of 40, it is known as premature ovarian failure. Then next one, hormonal disorder is hyperprolactinemia. Oligomenorrhea or amenorrhea can be there. There will be elevated level of prolactin and decreased estrogen level. We have to see if the prolactin is significantly elevated or if it is mildly elevated. Sometimes it is just above the normal range, it does not matter a lot. But if it is significantly elevated, we have to look for the cause. We have to look for signs as well. There will be galacturia. And we have to ask for the other symptoms also about the headache, visual disturbance, and in this case we have to do MRI of the pituitary gland if there is persistent hyperprolactinemia after ruling out primary hypothyroidism, because sometimes it is associated with primary hypothyroidism. So we have to, if we will correct the hypothyroidism, it will be automatically corrected. But if there is no hypothyroidism and patient is having persistent hyperprolactinemia, in that case we have to do the MRI of pituitary. And the treatment is dopamine agonist, which we know that these are cabergoline and bromocriptine, etc. Then according to the LH-FSH level, amenorrhea associated with normal or low FSH and chronic anevolution is frequently unexplained, because we know already that in premature ovarian failure the amenorrhea will be associated with high LH-FSH ratio, but if it is with low or normal FSH then it is unexplained. Most common causes for these are PCOS and hypothalamic amenorrhea. So now we will go to the PCOS. What is PCOS? PCOS is presence of two of the three features out of the ones I will mention ahead. These three features are usually present in PCOS patient, but for definite diagnosis we need at least two out of these three. Okay, first one is oligo or aneovulation. Second one is clinical or biochemical signs of hyperandrogenism, like there will be more testosterone. And third one is ultrasound evidence of polycystic ovaries. Sometimes the patients have the signs and symptoms of polycystic ovaries, but this criteria is not met, so we will not classify them at PCOS. For PCOS it is necessary to have two out of these three. Okay. Then hypothalamic amenorrhea. Functional disorders of hypothalamus lead to chronic anevolution, psychogenic stress, weight changes, undernutrition and excessive exercise. And then chronic debilitating diseases like juvenile diabetes, kidney disease, malignancy, other immune deficiencies and malabsorption, it can also lead to the anevolution and amenorrhea. Then hypothalamic amenorrhea is characterized by the inconsistent GnRH drive, while in PCOS, GnRH pulses are persistently rapid or increase. Hypothalamic amenorrhea is usually treated with cyclical estrogen and progesterone. And it also, we already know that HRT will prevent the osteoporosis, and the patient will need good nutrition. Optimal weight gain is necessary, and sometime if they are planning for pregnancy, we will give ovulation induction. Also, I would like to mention that anorexia nervosa and these malnutrition disorders like anorexia nervosa and the other one bulimia nervosa, they are also associated with hormonal disorders. Then evaluation of women with amenorrhea. We have to first take a good history from the woman, and physical examination of woman is important. Then we have to do the pregnancy test to rule out that there is no underlying pregnancy. Next we have to do the FSH and prolactin level. So it depends upon, if FSH is normal, then the patient might be having anatomic defects like the Mullerian dysgenesis, which can lead to vaginal atresia or imperforate hymen. Secondly, if FSH is high, then the patient can have ovarian failure. Third one, if prolactin is increased, then we have to rule out the cause for the prolactin after ruling out hypothyroidism. And if there is any need, we will go for MRI of the pituitary like radiographic evaluation. And if FSH is decreased or normal, then it can be PCOS or functional hypothalamia. Okay. So let's move on to the physical examination part of the primary and secondary amenorrhea. First I will finish for primary and then the secondary amenorrhea. For primary amenorrhea, physical examination consists of general well-built of the patient. We have to look at if the patient is underweight or overweight. Usually underweight patient have hypothalamic hypogonadotrophic hypogonadism, and our overweight patients have amenorrhea due to PCOS. Other than this, we need to look at the breast development pattern or staging for the secondary sexual character, examine for the hirsutism, acne, striae, increased pigmentation, any vitiligo, any signs of hypothyroidism, any signs of Turner development, and this is it. And let's move to the evaluation of the patient with primary amenorrhea. Evaluation of the patient with primary amenorrhea need pelvic ultrasound, and if something is not clear on the pelvic ultrasound, we need to go for the MRI of the ovaries and uterus as well, fallopian tube. Initial lab investigation for primary amenorrhea consists of serum HCG level, which is pregnancy test, FSH, TSH, prolactin, E2 level, and other than this, if TSH came out to be low or normal, we need to go for the further thyroid profile in the form of T3 and T4. Additional testing include additional testing include the results of these investigation to decide if we need any more investigations or not. Next one is secondary amenorrhea. For secondary amenorrhea, physical examination is almost the same, just there is little bit of difference in the investigation. Investigations for secondary amenorrhea consist of three major investigations along with the primary investigation. Serum prolactin we have to see, and other than that we need to concentrate on the FSH level and LH level as well. So the investigations are more or less the same. The third investigation which is needed here is serum androgen level as well. Management of the patient with secondary amenorrhea is treating the underlying cause. If possible, help the woman to achieve fertility and prevent the complication of the disease process in PCOS, obesity management, hirsutism management, metabolic disorder if they are the cause, lifestyle changes in the form of exercise, in the form of decreasing caloric intake if the patient is underweight, if the patient is overweight, if underweight, then decreasing the calorie intake. Other than this, nutritional counseling of the patient. Sometimes amenorrhea is due to eating disorder. In those cases, we need to counsel for the eating disorders as well. If the woman has good ovulation, then in those cases we need to go rule out the psychological causes by doing CBT. And if the patient is not seeking fertility, and the patient has amenorrhea, then in those cases we need to give hormone replacement therapy for restoring the bone mineral. In case of hyperprolactinemia, depends upon if the patient has macroadenoma or microadenoma. Each one has different treatment. Primary ovarian insufficiency, usually the treatment is in the form of dietary management and the medication are vary from if the patient is seeking fertility or only seeking the symptoms. So they give in the form of hormone replacement in the form of oral contraceptive pills, and sometimes they give ovulation induction and metformin as well. Other than this, if this is because of thyroid disorder like hyperthyroidism or hypothyroidism, then we need to correct the thyroid problem as well. Thank you so much. This is it about amenorrhea. See you soon in the next video. Thank you.